there's normally coffee?
Yeah, there's normally coffee. Joe, hi.
Morris, how are
Good
you?
to see you.
Thank you very much for the invitation.
Thank you very much for coming. Now, because we do, these now are international now. We're going to be the first of our, every week is international. We used to have every month is international.
Yeah.
Because we're using Zoom, it's readily accessible.
Right.
So what happens is, fewer and fewer people are coming here. We've already got 6 sites connected with video, and 8, I don't know what those 8 are. Those are 8.
Yeah, well, we watch you down at the Western.
Yeah, okay, oh, okay.
Yeah.
So what I'm trying to say is, this is like the classroom.
That all the things that we thought for sure were going to be, that people were going to learn, online and have this and have that, that has always caused a decline.
עכשיו שומעים אותנו.
To go? Okay. Okay, I'd like to welcome everyone to the next in our series of international behavior neurology video conference rounds. It's my pleasure to make an announcement that now all of our behavior neurology rounds are going to be international. And that's because we're using Zoom, which has great access. So every single weekly round will be an international round. And also we've started a registration process. And I hope that isn't delaying some people from joining, but from now on there will be a brief registration process to join us. Let me say that since they're international, These rounds are under the auspices of the Canadian Neurological Sciences Federation, the Canadian Neurological Society, the Peter A. Silverman Global eHealth Program, and the Canada International Scientific Exchange Program. Having said that, I'd like to turn to today's round, and it's my great pleasure to introduce a longtime colleague and friend, Dr. Joe Fisher. Dr. Fisher is professor in the Faculty of Medicine, University of Toronto. He's in the Department of Anesthesiology at University Health Network, a senior scientist in the Division of Advanced Diagnostics, the Cardiovascular section of the Toronto General Research Institute, and chief scientist at Thornhill Research in Toronto. His clinical interests are stroke and critical care, and his research interests are cardiovascular anesthesia and neuroanesthesia. And Dr. Fisher has it's a long title for these rounds, and I'm going to let him explain it, but I really like the last part of his title where he says, maybe things ain't exactly like we always thought. So I'm going to hand over to Dr. Fisher.
Thank you very much, Morris. Morris and I go back a long way, where we actually used to fight with each other. He'll tell you about that later. We tried not to hurt each other too much, though. So basically, how did I get here? I'm basically an anesthesiologist. So how did I get into this thing? So at the beginning, I developed something called sequential gas delivery. That doesn't mean much to you guys, but what it does, it gives us an ability to control the arterial blood gases. And we can do that now independently of how people breathe. I'm going to show you some examples of how that helped us get to where we are. So it's independent of how they breathe, or actually whatever they do. I had a few other little inventions here and there. So the hospital threw me out of the hospital, and they forced me to get this company up and running, of which they are. It's basically a spin-off company from the University Health Network. They own all the IP and stuff like that. So this company now developed this ResPrac, which I'm going to show you how we use it in a moment. Have a bunch of grant support, and as Morris said, I'm going to be showing you a bunch of stuff. Some of it is research, some of it is opinion, hypothesis, speculation, and off-label stuff. So I'm warning you, this may be dangerous to your thought process here. But just to get everybody, I don't know what the background is of everybody, but just to get everybody on the same page, I'm just going to go through this very quickly. So basically, we measure flow with MRI. We use something called the Bolt signal. And it works because the oxyhemoglobin is paramagnetic and dampens down the signal. So the higher the flow, the lower the deoxyhemoglobin, the greater the Bolt signal. The way I remember this is high flow gives you high signal. High signal means that the flow is high. Straightforward. So we use a stimulus to increase the blood flow in the brain. This, by the way, gives us a very high spatial and time resolved map of the changes of flow in the brain. And this is what is going to be the main part of my talk over here. And then we define cerebrovascular activity as a change in Bolt signal, which is basically the change in your flow, per change in PCO2, per change in stimulus. All right, so basically if you look at the surface of the brain, you have your Peel vessels, you have your penetrating arterioles, and there's a three-dimensional space called a voxel, sort of the equivalent, three-dimensional equivalent of a pixel. And we interrogate that. And we assume, even though we know that there's multiple blood vessels and capillaries, we assume that that is like a single vessel, the equivalent of a single vessel inside a voxel. So we look inside that voxel, and we assume it's a single vessel. The oxygen extraction is, we assume, constant along this vessel. And as the blood flows, oxygen is taken out of the red blood cells and you get the deoxyhemoglobin, which, as I showed you before, deteriorates the bold signal. So we look at the change in flow here. Then we increase the PCO2, say from 40 to 50. This increases the flow. If the oxygen extraction is the same, the amount of deoxyhemoglobin is less. Right? There's a bigger flow, same amount of extraction, so there's less deoxyhemoglobin, which gives us a bigger bold signal, like that. And we take these two bold signals, we subtract them. That gives us our delta bold, divided by the change in the stimulus, which we do in PCO2. So that's about a 10. And then we take that number and we color code it. Okay? So now we go back to our voxel and we color that voxel in whatever that CVR number was. All right, pretty clear? So we end up with a map that looks something like this in the patient. So let's interrogate this voxel, but look at it in the time domain. So here we took the PCO2, which is on this axis, and we changed the PCO2 by lowering it and raising it and then coming back to control level. We look at the bold signal and it follows it very carefully, very accurately. That's what happens there over time, okay? But we need to get it down to our index. How do we look at that? Well, we take the difference in bold signal, which is on this axis over here. These are arbitrary units. And we get some number, and then we look at the differences in the PCO2. We get another number, and this gives us, for this whole voxel, even though this was in the time domain, we reduce it and give it this index way to label that. All right? Now, please note that the bold signal very much follows the PCO2 because the blood flow follows the PCO2 everywhere in the brain. The higher the PCO2, higher the blood flow. Okay, so let's interrogate another voxel. So we come and we interrogate this voxel. Look here. Oh no. The blood flow, as the PCO2 goes down, it should go up. It should go down, sorry, with the PCO2, but instead it goes up. The PCO2 goes up. The blood flow needs to go up, but no, it goes down. And then it comes back. So how do we explain this? This is explained by the distribution of cerebral blood flow, which I'm going to go through now, and that'll get us on the same page. Then we're going to look at the implications of this. All right, so here's a patient with right severe carotid stenosis. And we do the CVR. Again, we cover all the voxels. We label all the voxels. And we find that on the side of the lesion, on the right side of the brain, there is this paradoxical flow. How do we explain that? Well, the first thing to understand is that in the carotid artery, and this is generally true as the vascular tree expands, the inflow artery, the main trunk, can never provide as much blood flow as the various branches can actually tolerate. There's always a bigger capacity for flow as you go distally. So in a way, the initial artery has a kind of inflow resistance or inflow limitation. Okay, here you have your lesion. And what happens up here is that you have a decrease in vasodilatory reserve. You have autoregulation taking place. The brain tries to maintain its blood flow past the lesion until it just can't anymore. But in many of these people with carotid stenosis, they walk, they talk, they drive their car, and they clearly can. Now we come along and we increase their PCO2 tremendously. So the good vessels dilate, which redirects the flow to those good vessels. The pressure drops proximal to the lesion, and the flow distal to the lesion goes down. Okay? So the flow is still a function of PCO2, but because of the hemodynamics, you get a drop in the blood flow in the area distal to the lesion, and therefore you get this, the paradoxical flow. So the better the flow here, the worse the flow here, and they are opposites as I showed you in the first few graphs. Okay, is this clear? Yes? All right. So what happens then is that we raise the PCO2, but in these vessels, distal to the lesion, the blood flow actually goes down, the deoxyhemoglobin goes up, so the flow goes down, the Bolt signal goes down, and the ratio gives you another, a lower number. We color code that, and that's how we get those blue voxels. So here's another patient with the left carotid stenosis. And what's going to be the CVR on this side, Morris? It should be like this, right? It should be like that for the same reason. For the same reason, you've got your stenosis, you've got your increased PCO2. The CVR should be the same, but it's not. It's not. Wow. How do you explain that? So this was very disturbing to us as we saw some of these things where we were sure that this patient should have had a decrease in flow over here. So the explanation here is that some of these patients develop collateral blood flow. Okay, so again, you've got your inflow resistance here. Autoregulation is not invoked distal to the lesion. So you have good vasodilatory reserve in both of these areas. Then as you increase the PCO2, both of them are able to dilate. And the extra flow distal to the lesion comes from this collateral blood flow. Okay, so that's the hypothesis that we work on over here. And where does that all come from? Well, looking at, again, this is to represent the surface of the brain. This is the circle of Willis. Some of it comes around the circle of Willis. On the surface of the brain, you can have the interconnections with the PL vessels on the surface increasing and sharing blood flow, going from the PCA frequently to the MCA. You can also have it going the other way around. You can get blood flow also through the circle of Willis. But even in the penetrating arterioles, and there's a continuous capillary network, and all of these are conduits for collateral flow. Looking at the brain here, this is being seen pathologically as well. Looking at the insular vessels over here, they can see vessels coming with flow coming in this direction, and also from the striates coming in the opposite direction. Here in the centrum semio-valley, there are very few such opportunities for collateral blood flow, and clearly that is where all our troubles come as humans. So this is the second most important slide in my talk. So as you're assessing the carotid stenosis in the patient, yes, you're going to do a ultrasound over here, but that's not where the business is. The business is in the parenchyma. You need some tests to see what blood flow is coming to the parenchyma, because your ultrasound over here just tells you what's distal to the stenosis. So if you take both of these patients, they will have the same ultrasound, but they will have clearly different blood flow to their parenchyma, basically due to this collateral flow. Okay, now I'm going to take a little sort of side thing that is going to be used for some discussion later. Okay, so I'm stopping there. That's like 1 unit of information. I just want to go through this quickly, show you how that applies, and we can use this in some of our discussion coming up in a few minutes. So you have some carotid stenosis, fine. You get some autoregulation, fine. Generally, you might get some decrease in perfusion and some reduction in cerebral blood flow. But because of the autoregulation, often the cerebral blood flow doesn't go down until things get quite severe. You might get some ischemia, and it can lead to an infarct. Certainly, if you have a thromboembolism, this makes things a lot worse right away, and there's no way to deal with that. So what actually does happen as your stenosis gets worse and worse, and you still walk, talk, play cards, and drive your car? Well, the chronic ischemia has some trophic effects, and you develop these collateral vessels in the areas which I showed you in the previous slides. So when you need it, you can recruit some of these vessels, improve your cerebral blood flow, and there's some trade-off here, an equilibrium between the ischemia and the cerebral blood flow. Depending on the balance, it's possible that it would lead to an infarction. So what about obstructive sleep apnea? Well, sure. So this is the big deal. So when you're young and you have this, you're at great risk. But with time, the obstructive sleep apnea helps you because it also decreases your perfusion. At the same time, it decreases the PO2, increases the amount of ischemia in your vessels, gives you these tropic effects, and increases the amount of cerebral blood flow. But we can still have strokes, right? You have a very long sleep apnea. Your PO2 goes down a little bit more than it could. The collateral flows haven't really compensated or developed adequately, and you can actually go to infarction, and that's often your wake-up stroke, which you probably had in the middle of the night. So it's a kind of balance here. You know, when you're young, this is a big risk, but once you get older and you've developed these things, these are the things that save you, and you don't have to treat the sleep apnea anymore because you're okay now because you've developed your collateral blood flow. Crazy, eh? Again, you saw my disclaimer at the beginning. You don't have to believe any of this. But there is good literature for that, and if you want some of that literature, if you email me, I can send you the references for that. So is CBR really a good marker for stroke? Well, this is a paper that has some very big names in it, including Randolph Marshall and Katharina Klein and others. And so when they look at that, they see what are the big determinants of stroke. Yes, there's the age, but interestingly enough, carotid occlusion and collateral and stenosis on the contralateral side actually are not related. Crazy, not related, not. The big one is cerebrovascular reactivity, and this is from their study. Depending on how these are two ways that they happen to scale their cerebrovascular reactivity. So the risk rate, the lower the cerebrovascular reactivity, the higher the risk rate for stroke. That's from that paper. This paper I like a lot too, from Gupta et al. So they looked at 2,238 articles, of which they picked about 12 articles, 1,000 patients that had greater than 70% stenosis. And they looked at the CBR, and it doesn't matter how you measure the flow, whether you use a bold signal the way we do it, or whether you use CTA, MRA, and it doesn't matter how you challenge them, it doesn't matter how you use the CO2, it doesn't matter, nothing matters. And it doesn't matter what you use as your outcome, whether it's symptom, stroke, or this or that. The number one determinant, predictor of stroke is the CVR.
Joe, because some people came in late and the registration may have slowed people, can you just redefine CVR?
Yes, the CVR is per voxel, the change in flow, whatever your flow metric you use, for the change in stimulus. In this case, in our case, we use the bold signal as a high spatial time resolved indicator surrogate of flow, and we use CO2 as the stimulus. We give a precise CO2 stimulus, as I'll show you in a moment. So this CVR, this is the number one, other than the age, this is the number one predictor of the risk of stroke. So we looked at our data. We looked at our data in the Toronto Western Hospital. This is just like for your interest, not terribly rigorous. But we looked at patients with these are all symptomatic patients with lesions. 24 had a normal CVR, 76 were impaired, and some of these had interventions, some didn't. These weren't randomly picked. They didn't have interventions because the family didn't want, or the surgeon couldn't reach the vessel, or whatever. But what happened to them is of interest in that the strokes occurred in these people that had impaired CVR, and none of these had a stroke. None. So that is consistent with what they found. So we went on to look at to see if the degree of carotid artery stenosis was related to the reserve, to how much CVR you had. This is before we really understood this stuff about the collateral flow and stuff. And we want to see how effective it is. So we looked at reserves in symptomatic patients, and we want to correlate the CVR with carotid artery stenosis. This is work from our graduate students, Olivia Sobchik. And this is the most important slide in my whole talk. After this, if you have to go somewhere, you can go. This is the slide. The second most important was the one that I was telling you, the stuff is in the parenchyma. That's where the information is, not at the carotid. This is the most important slide, and I'm going to walk you through that. So, this, on this axis, is basically another score of CVR. I can't explain this here because I explain it later in the slide, but for now, so this is the average CVR in the MCA territory. You can look at it like that. And along here, you have the degree of stenosis. So this is 70, greater than 90, 100. This isn't a linear scale. And this is less than 50, and this is 50 to 69, which is supposed to be not significant, okay? This is sort of the normal range. This is the number of people who had above the mean, and these are the number of people who had below the mean, but within the normal range, these are all healthy people. All right? If you go with the Doppler, you pick up these people as being abnormal. But what you have is you have a bunch with normal CVR, right? If, again, with the Doppler, you pick up these as being normal, but these have low CVR. And that's what I'm going to talk about in the next few slides to see the importance of this. Is this important? Is it only important what you got with the Doppler, or is this important? We'll have a look at that. If you follow and continue to follow what I was saying, these people with the normal CVR and abnormal Doppler are actually false positives. You get an abnormal Doppler, but their CVR is normal. These are normal people. My interpretation, these are normal people, okay? And similarly, these may have less than your 70% stenosis. You don't tap them on the head and send them home. These are abnormal. Let's think about this. In the studies, like in the CREST, they use this. They use all these guys as their cohort, and they treat them with best medical therapy. Well, they're going to overestimate, if these people are actually false positives and they're good, they're going to overestimate the value of best medical therapy because these guys don't need any therapy. So if you give them best medical therapy, of course they'll do well. Similarly, they don't need any surgery. So if you operate on them, you have no chance of making them better. No, none. But they still have the risk of the operation. So clearly, you're not going to get, it's futile to do this study. And I went down to the Mayo Clinic and I told them this. Because they're the ones that are running it, even though it's multi-center. All right, so is if the CVR is normal, you might say, why are they getting TIAs? Because all the people that we got already had TIAs. That's how they were selected and sent to us. So why would somebody with a normal CVR have a TIA? Well, first of all, there's incomplete compensation. Nobody compensates perfectly. So they still have some autoregulation that they invoke, and the vessels, they don't have full reserve in those areas. Second, the collaterals don't work like your autoregulation. When you need autoregulation, you get it. Collaterals are a different story. This is a hemodynamic compensation. You have to have a drop in resistance somewhere, changes in flow, and it would take some time before it comes. And there's no feedback loop. You know, you don't know when you're getting enough. So you may have a transient period where you do have too little flow for function, but enough flow to maintain cellular integrity, right? So the bottom line here is that as long as you have good CVR, you'll maintain your cellular integrity, and the fluctuating symptoms are not a risk for stroke. All right, so it's reassuring. They can tolerate ischemia much longer. And in fact, when you look at the literature, there's a lot of indication for that, because if you suck out their clots, they're all softer and smaller. They have partial perfusion, so when you give them the clot busters, they actually get there. It's not a complete occlusion. So these people have, they're maintaining their cellular integrity, and they'll have longer viability for their brain. So you might be able to suck out their clot past the magic 4 or 6 hours or whatever, maybe the next day, or maybe you don't need to, because they're maintaining their cellular integrity, and the size of their infarct will be smaller. And they may have good ischemic preconditioning, because they're getting some flow, and that may give them acute ischemic preconditioning. So will that revascularization help them? I propose very unlikely, very unlikely. You have nothing to gain by operating on these people. What about best medical therapy? Sure, why not? The thing that we don't know is whether these people develop cortical thinning and dementia. We do know that if you have an abnormal CVR, the patient with the blue side of the brain, we've shown that you get cortical thinning there, and if you revascularize them, you get cortical rethickening. What's in there, we're not sure, but certainly the surgery, the fact that they have an abnormal CVR there affects them, and when you revascularize them, they thicken back up, so there's some. Whether these people also have a problem, we don't know that. All right, an example that we preach, that we practice what we preach. This is a 75-year-old guy, and he came in multiple neurologic episodes of neurologic symptoms, aphasia, right-sided weakness, lasting minutes. He had had a previous infarct. He has a carotid occlusion. And we did the usual tests, and he has delayed flow on this side. And he was admitted to the neurology service. He was put on IV heparin, and he continued to have symptom after symptom. And they were wondering, you know, should we bail out on this guy and just send him to the surgeon and quickly revascularize him before he strokes? So we sent him for a CVR. And his CVR is like this. So we continued to treat him with some comfort that he wouldn't stroke out, and he didn't. And 7-week follow-up, he was still fine. He's still fine as far as we know now, with even long-term follow-up. All right. So normal CVR is reassuring, but is it impossible for them to have a stroke? No, it's still possible. They can still have a stroke. You can have an obstruction that's too long, an obstructive sleep apnea that's too long, too severe. Something can still happen, they can embolize and so on. All right, now what about these guys? The guys with the small lesions in their quote non-hemodynamic significant lesions. All right, so if they don't have a hemodynamically significant lesion, why is their CVR poor? How can you have a non-hemodynamic significant lesion and have an abnormal CVR? Doesn't make sense in a way. So the explanation we have is like this. Maybe it is hemodynamically significant. Sure, at rest, it's not hemodynamically significant because the blood flow is low. But when you increase the PCO2, there may be changes that are in the lumen that makes it such that it develops turbulence and develops increased resistance. And it depends on what the lesion looks like, right? And the profile of the lumen. So there may be some hemodynamically significance that's not strictly related to the degree of stenosis. All right. Can people with less than 70% have a TIA? Well, they have no hemodynamic effect at rest, so they don't really recruit their autoregulation. They're getting perfectly good flow. But they also don't have any collaterals because they never had the ischemic episodes, unless they got it from their obstructive sleep apnea. So these could be risky lesions. And symptoms in them could be very worrying. It's the OSA that helps you because it gives you this chronic ischemia and it helps you with the preconditioning. And we don't know if they've had that or not, or if they've had it long enough to develop the collateral blood flow. So should we do CVR in patients with less than 70% lesion? Well, let's see. Let's say it's abnormal. Then either the lesion, even though it's less than 70%, is hemodynamically significant. It's either that, or they don't have good collateral flow, or both. They should have both, and they're at higher risk. But if their CVR is normal, then either the lesion actually isn't hemodynamically significant, or they have collateral flow and their risk is less. So CVR would help us even if the lesion was not hemodynamically significant. Again, because we're now looking at the parenchyma. We're not looking just in the carotid artery. So how do we, so this is the last part of the talk. I've given you the meat and clinical potatoes, and this is just, I'm just going to run you through how we do these little tests. So the first thing we did is we standardize a stimulus. If you do a breath hold, you get a variation in stimulus over time and the extent, sort of drawn by me here. And it varies from person to person, varies each time you do it. And this is not really, doesn't have the requirements for a clinical test. So there's no point in doing that. So we developed a method, the aforementioned Respirat, where we can actually target the exact PCO2 that we want in the patient, independent of how they breathe. So the blue dots were the targets, the black dots are the actual end-tidal PCO2s in the patient. And we've already shown that these end-tidals are equal to the arterial PCO2. It's not a simple way of doing this. It's actually quite technologically complex and expensive. This is what it looks like in our MR. This is the machine. There's another device with a computer screen in the control room. There's a umbilical cord going to a mask that is sitting on the patient. So basically what we do is we give a profile stimulus that we know of, and then we look and see what the change in hold signal does in the voxel. But if you look at different voxels, you get different changes in the signal. So the question is, how do we know which one is normal for that location? How can we normalize the CVR for that location? So the way we do that is we take 50 people, we give them, we give each one of them the same stimulus, and then we take that voxel and we look at the mean and standard deviation for each voxel. Okay, so we take all the 50 people, we co-register their brains, we pick a voxel, and we look at the same voxel in all the brains. And then we do a mean and standard deviation of the CVR in that voxel. So then when we get a CVR that looks like this, which is sort of uninterpretable, we change the CVR in each voxel, we give it a Z-score, and the Z-score from the format over here, you can see, is basically gives us the chances, the probability that this is normal, that this is within the normal range. We take the CVR, we subtract it from the mean, and we divide by the standard deviation to give us a Z-score. And if we look on the Z-map, we can see that these dark purple voxels are more than 2 standard deviations in CVR below the normal. So even though some of this looks normal, we can see most of it is on the abnormal side, and we can see the areas, like such as this area, which we wouldn't have guessed would be 2 standard deviations below the normal. It gives us a better resolution of the CVR in the patient. So here's another patient with ICA stenosis. Not surprisingly, he has steel on one side. But when we do the Z-scores, we see that the other side isn't so healthy either. And neither is the rest of the brain. This patient has severe problems. Here's a guy with bilateral carotid stenosis. He's going to be terrible. Maybe not. Maybe he has collateral blood flow and his CVR isn't bad. But when we do his Z-score, we see he's in the lower range of normal. As I showed you from Olivia's graph, that all these people with the high stenoses, they came in the normal range, but they were all in the lower range of normal, as is this guy. So how far have we come from the Z-scores? Well, we've normalized for anatomical location. You can further normalize it for age, sex, and everything else. If you happen to have, 30-year-old patients that you're looking for MS or something, you can have your atlas to be just narrowed down to that. The good news is that the Z-score is compatible between scanners, institutions, and our sequences. As long as the stimulus and the collection is the same for your atlas as it is for your patients, your Z-score ends up being like an INR. It is the same. Your Z-score will be the same as ours, will be the same as Joran Fierstra's in Zurich. Okay, and the final thing is we've been able to look at longitudinal data. Up until now, all studies are cohorts. You can look at this cohort, you can look at that cohort, but you can't pick out one patient and follow him from time to time because you don't know what his test-to-test variability is. So we've normalized for that test variability. So here's a patient. He has a CVR map made on day 1. He has another one made on day 2. So what we do is we subtract every voxel and we get a map like this. And we look at the standard deviation for every voxel. Okay? Then when we get a patient, we take that voxel. The mean difference always is going to be 0. So we subtract 0 from that, in other words, leave it at. But the number that we need from the atlas is the standard deviation. And this gives us a Z-score, an interval difference Z-score. It tells us how the patient has changed between the last test and this test. So here's an example, and I end with this. So this was a patient that I think had carotid stenosis. I can't recall if this is moi or carotid stenosis. Anyway, he has his surgery, has a bypass, and he's like this. And then over time, at 8 months, 18 months, and 35 months, he does this. So here he's clearly better, but here we're not sure. He looks worse, whatever. If we look at the Z-scores of those, we see all the places where he did get better between before and after surgery. And then we see when he came back at 8 months where he got worse. When he came back at 18 months, we see he's now getting better in all those territories and continues to improve at 35 months. And overall, this is his overall difference. If you didn't have the test variability, you can't do this. You can't follow people to see if they're getting better or worse, or if your intervention did anything. So we started the standardization of stimulus. This is Dave Michaelis, in whose lab I work, and we do this work together. This is the first version, this is the third version, and this is the final version of this same machine that we have been doing for about 20 years. So in this talk, I told you, I defined for you the ability to define a normal CVR. The advantage is that you can quantitate abnormalities in a single patient on a single visit. So you don't need to do just cohorts. And you can follow the CVR in an individual subject between visits. I gave you a clinical model of the assessment and management of the risk of stroke. And I just want to emphasize again that the data is compatible across centers, so that if you do what we do, we can actually share that data in the form of Z-scores. And any questions?
Okay. All right, so Joe, you stay here.
Yeah.
We're going to questions from Baycrest, but what I'd like to do is start with our provincial and international partners. So I'm not going to go from site to site. If you have a question or a comment, just speak up. Any comments or questions from our partners? Okay, we're going to go to Baycrest. Dr. Churko has
That was a fascinating presentation. I'm just sort of knocked over by what you're saying. So I have 4 questions, but first one is I want to understand this. If you were looking at, and we're talking about the effect on stroke, you've got carotid stenosis, and you've got the CV reactivity. If you're doing like structural equation modeling, are you saying that the effect of carotid stenosis on stroke is all mediated by its effect on CV reactivity, or are they independent contributions towards stroke? That's what I didn't quite understand.
Yeah, that's a good question, and I fudged that. That's my fault, and I sort of fudged back and forth on that. So I started off telling you that your risk of stroke depends on your collateral blood flow. And our only ability to measure collateral blood flow is looking at the response in the parenchyma. So, and I pushed CVR for that. And then I fudged, I sort of dirtied the waters by telling you that this collateral blood flow is a kind of variable in people. Some people can develop it quickly. Some people already have it at birth. Like again, I'm extrapolating from rat studies, that some rat species have excellent collateral blood flow right from birth. Some people never develop it. Some rats never develop it, even if you make them ischemic for long periods of time. And some will develop it with ischemia. And I'm pretty sure humans are the same thing. So by talking about the obstructive sleep apnea, I was basically saying that we are adaptable, and people have the potential that even though that they have risk to their perfusion by obliteration of their major cerebral arteries, they can develop collateral blood flow to mitigate that risk. Okay. Did that answer the question?
It really answered my question.
Okay.
I mean, what is your thought? Do you think that are you saying, let me rephrase it. Are you saying that if doing measures of CV reactivity was simple and inexpensive, that we should stop doing carotid Dopplers and go to measuring CV reactivity if we're trying to assess stroke risk?
Yeah. So like leaving aside the fact that it's difficult to get at and it's extremely expensive, leaving that aside for now, because that's a social issue, not a medical issue. So yes, you can do the Doppler as a screening procedure. I think that if you have carotid stenosis on the Doppler, I'm going to pick a number arbitrarily, say 30% or more, and if CDR was generally available, like, you know, they just go up to the lab and wait 20 minutes and get their CDR. Sure, the CDR is your real risk of stroke. It's not the degree of stenosis, as I showed you. Yes, overall, in general, over a large cohort of 70 people, it's sort of, your risk varies with the degree of stenosis. But at any degree of stenosis, you have the full range of full collateral blood flow to no collateral blood flow. And if you can separate those, you have a better idea of the risk of that patient and who you need to revascularize, and for whom revascularization would be exposing to a risk of surgery for no benefit. That is a big difference. Then there's the social issues of, you know, how do I get to an MR and how do I get to do this and whatever. You know.
So let me take it one step more, and then I'll stop for a bit. So we're behavioral neurologists interested in cognition, and the big question is always, in any particular patient, how much is the vascular factor versus the Alzheimer disease responsible for the cognitive change? And what we're looking at for measuring vascular risk factors or an MRI infarcts, or sometimes presence of carotid stenosis. Would you think that perhaps a better way to assess the vascular contribution to cognition might be looking at CDR?
Okay, so that question was whether CDR may be a better metric for assessing patients with cerebrovascular disease for risk of dementia. So the answer isn't straightforward. My answer isn't straightforward. So let me take the easier one. If the patients do have carotid stenosis, and I define that vaguely according to Olivia's graph, somewhere along there, I think it behooves you to look at whether or not their CVR is abnormal, because there's an intervention that you can do something about. Okay? If they don't have good collateral blood flow, you may consider the intervention based on, now there's two articles. There's ours showing rethickening of the cortex, and there's now been another paper published from an independent group who repeated that study and found the same thing, that there's rethickening of the cortex. And there are lots of anecdotal articles that say people improve their cognition after they had their carotid surgery, probably put out by the surgeons. You know, teachers went back to work, an accountant went back to his accounting practice, and so on. I don't know if there's any real systematic indication that intervention surgically. Now, then after that, the question becomes, if there is collateral blood flow, is this as bad as if there wasn't collateral blood flow? I mean, again, I asked that over here. Then there's the microvascular issue, which we have also shown that the CVR is an important marker for the microvascular disease throughout the brain. Certainly, we showed it in the white matter with white matter hyperintensities and so on. Now, how that's going to help you, like tomorrow, manage the patient in your clinic, I'm not sure. But if we don't start looking at these and looking into this, you know, we're never going to get to where we can actually intervene.
Okay, let's go back to our other sites. Comments or questions, just speak up.
This is Dr. Sneha Bharadwaj calling from Australia. Dr. Fisher, that was a fascinating talk, and certainly a lot of horizons open up in asking oneself, how does this translate into clinical practice? The one thing I must say is that there is a disconnect between your concepts in application to different forms of dementia. For example, you're speaking almost exclusively of vascular cognitive impairment as against Alzheimer's, as against pathology of different proteins, which have a major role to play in clinical presentations. I can very well understand that the circulation, the collaterals, the surface parenchyma matters, but this still has to carry itself out in more studies, more research to see what we can do to help these patients, because apart from the group of behavioral neurologists sitting almost everywhere. I am a geriatrician. And by the time my patients come to me, they do not really qualify for even carotid artery stenosis because there's an age factor, a treatment, surgical treatment, because there's an age factor. But yes, there is a paradigm which says that we have to look for and treat obstructive sleep apnea, which will improve cognition and which may actually take away one vascular risk factor. And here's where the paradox lies in your teaching, that obstructive sleep apnea in an elderly patient may be protective towards a vascular cognitive risk factor. Can you explain that?
Yeah, well, I was very provocative in that, but I'll tell you that the obstructive sleep apnea may actually be beneficial to young people, but once you get above age 50, it's probably of little benefit to you, whatever collateral flows that you have in your heart. And people have looked at, again, in the heart and in the brain is probably established by then. Treating obstructive sleep apnea after the age of 50 or 60, I'm not sure if that would be beneficial. If you treat younger people, say before the age of 50 of their obstructive sleep apnea, you will prevent those strokes that occur from very severe obstructive episodes. But on the other hand, you take away their ability to develop collateral blood flow as they go on later. Now, these are hypotheses that are, again, in the literature. If you email me, joe.fisher@utoronto.ca, joe.fisher@utoronto, just the letter U, toronto.ca, or you can get it from Morris or my email. I can send you some of these studies that have said this, that you have to decide what you're going to do to treat them. I know there's a big industry of treating obstructive sleep apnea, but myself, I'll tell you, virtually everybody has obstructive sleep apnea, everybody. Why would evolution allow everybody to have obstructive sleep apnea if it didn't have some benefit? Okay, everybody has it. Not everybody goes past the threshold of 15 or 20 or whatever AHIs there are, but everybody has some, and it may be of some benefit. I just throw that out as a provocative. I'm not certainly a sleep apnea expert, but I just want to throw that out to be provocative.
Go ahead.
One small thought to share with you. I run a memory evaluation unit, and I look for reversible causes of cognitive change, because memory evaluation units are looking at patients who don't have established dementia but are at a risk of converting. And I have had very good success in treating obstructive sleep apnea of patients in their late 70s. And I'm looking primarily for Alzheimer's because it's the run-of-the-mill dementia out there. So my experience is different from your philosophy, and I'll be watching this space. But I'm fascinated, and thank you for sharing.
Joe, let me just ask you, you're talking about obstructive sleep apnea and cerebral blood flow, but there are other benefits for hypertension, for example. Would you extend your comment that in the elderly or past a certain age, treatment of obstructive sleep apnea wouldn't be protective, let's say, for hypertension?
Right. So obstructive sleep apnea is a complex disease associated with hypertension, obesity, and increase in inflammatory reaction and various other things. So it's more complex than I present. And surely, you know, as the speaker from Australia says, you know, you have to weigh these things. These things are sort of a little bit complex. But I threw in mine with a little bit of extra force because it's something that people don't think about. So I think I wouldn't recommend a radical change for now. I would still, you know, be cautious. But let's think about it. You know, things aren't always like we thought.
Right. Okay. There's a question. Other questions from our partners before we come back to Baycrest? Just speak up. Okay, we have a question from Baycrest, Dr. Verhoof.
Thank you for your excellent presentation. Given the importance of the cerebrovascular reserve, with what you would know, like what factors actually are determining that individual differences of cerebrovascular reserve and collateral formation, and would there be other potential approaches, either medication-wise or exercise or other lifestyle factors that might improve your cerebrovascular reserve?
Yeah, so the question was, how can we improve cerebrovascular, yes, this, brief, yes. The question was, how can we improve collateral blood flow and cerebrovascular reserve? I'm not sure of any kind of medication that you can do, but certainly a good lifestyle, exercise, and all those things, particularly exercise, will optimize your chance of developing the collateral blood flow.
Okay, we're close to 9 o'clock, and before I thank our speaker, Dr. Fisher, I just want to reemphasize for those who joined us late that all of these rounds every week, because of our Zoom technology, are now going to be international. So there will be flyers sent out, and you're all invited to join us on a weekly basis. Now I'd like to thank Dr. Fisher for a very interesting, highly educational, and provocative presentation. That was really great. Thank you, Joe.
Okay.